really happy to present our speakers from today. So we have from Maceió, Brazil, Dr. Bruno Freitas. Welcome. How are you doing today?
Thank you, Lorenzo. Thank you, Bruno. It's a pleasure to be together with you here, Bruno, Giacomo, Sergio.
Thank you.
I'm sure we have a profitable time.
Thank you. Then we have Dr. Giacomo Misernia from Perugia, Italy. Welcome. How are you doing?
Fine. Thank you, Lorenzo. Thank you for your kind invitation. It's a pleasure to be here from me. Thank you.
Thank you. Thank you for your time. And last but not least, we have Dr. Bruno Migliara from Peschiera del Garda. Hi, Bruno. How are you doing?
Fine, thanks. And I'm really proud to be here with you.
Oh, thank you very much. I pass the word to Dr. Migliara's presentation and enjoy the presentation.
Okay, now I'm ready for this presentation. In this presentation, it's a possibility to evaluate the effectiveness of mechanical atherectomy and thrombectomy devices in a very complex, very tricky situation like a bypass occlusion in patients with CLTI. In literature, there are not so many publications about the clinical outcome of bypass failure, but this publication, above all in patients with CLTI, show well that this situation is related with higher risk of limb loss between 50 to 75% at 2 years. Then this condition is a very complex, very distressing condition for every vascular surgeon. We can treat this patient with open surgery, of course, with local thrombolysis and with thrombectomy devices. Open surgery, of course, ruling out the Fogarty thromboembolectomy due to the no effective result of this treatment is based on the redo bypass surgery, but redo bypass surgery in patients like this with many previous surgical revascularization in the same leg, treatment is related with high morbidity. Then also based on the 19th trial, then the Topaz trial, local thrombolysis has become an alternative treatment in this patient, but we know well that local thrombolysis is not effective in subacute and above all in chronic occlusion. In some patients is too slow to restore the flow, and then has some limitation and a lot of complication. We can also finally use the percutaneous thrombectomy devices, but literature data about these devices are few and show some limitation. Then, based on this not completely satisfactory result of the different type of treatment in patients with bypass failure, we have started to use the mechanical atherectomy with thrombectomy devices, then the MATH, and then using Rotarex S. Now, a short video, clinical case to better explain the procedure, the clinical, the effectiveness of this device and the tips and tricks. This is a female with a very long history of a CLTI into the right limb with a previous stent, occlusion of the stent, bypass, occlusion of the bypass. But at the end, this patient came back in our department last November with this situation into the foot with a lesion into the foot. Then we decided to treat this patient and to try to reopen the previous bypass. Usually in this patient we start the procedure with an antegrade ultrasound guided punch artery, and we place the the sheath at this level, and we perform the first stage to have a general view. Then we start with the procedure, and usually using a Borenstein catheter and eventually an hydrophilic 045 guide wire, we cross the proximal and occluded anastomosis. But in some cases, like in this specific case, when we arrive with the guide wire, the distal anastomosis, also changing the guide wire, the support catheter, is not possible to cross the distal anastomosis and to regain the true lumen into the tibial vessel. We can see well here that the guide wire goes retrograde into the native pop artery. And then in this case, we decide to perform a retrograde distal puncture of the anterior tibial artery. In this case, using a V18 guide wire and a 6i support catheter, we go retrograde into the anterior tibial artery, and then it's quite easy to cross in retrograde way the distal anastomosis, and then we regain the guide wire to the proximal sheath, and at the end we shift another time from distal to proximal. We place a specific 018 guide wire for Rotarex into the anterior tibial artery. And then we decide the type of Rotarex. In this case, we choose the 6-French device because we prefer this in case of below the knee bypass. In case of above the knee, we prefer 8-French device. We place the head of the catheter a few millimeters above the proximal occlusion. We start with rotation, this to activate the aspiration. An important marker of the active aspiration is collecting bag outside the body during all the procedure. In absence of the blood flow, we stop the procedure, we wash another time, we clean another time the device, and eventually, like in this case, we perform a proximal PTA of the proximal anastomosis. This in order to improve the inflow. Then we restart the procedure with a typical forward and backward movement. Not more than 1 centimeter per second in order to remove all thrombotic material. We stop the procedure few millimeters above the distal occlusion. We maintain a distal plug. This in order to inject contrast medium and to see in a retrograde way the effectiveness of our treatment. When we are sure to have removed all thrombotic material, we go very slowly to the last part of the occlusion. This in order to reduce the risk of the distal embolization at the moment of the flow restoration. This is the final result. Then with a very good, very rapid flow through the bypass, and with an improvement of the flow into the foot. With this device, it's possible to recanalize every type of bypass, like this above the knee bypass, or this biosynthetic venous composite and prosthetic below the knee bypass. Now, our experience, we performed a study to compare the clinical outcomes, but also the treatment, comparing open surgery and MAFT in patients with acute, subacute, and chronic bypass occlusion. These are our clinical and cost endpoints, and we apply in this patient the cost effectiveness analysis. This in order to find an eventually dominant therapy. In this study, we analyzed 48 consecutive occluded bypass, treated 17 with open surgery and 31 with MAF. The two groups are homogeneous regarding demographic characteristics and comorbidities. The only difference is in gender distribution, because in the open surgical group there are only male. all patients with CLTI, and many of them with in Rutherford 5 class with no differences regarding the Rutherford class distribution. Again, two cohorts of patients are completely homogeneous regarding the period of occlusion, more than 70% in both groups with a subacute or chronic occlusion, and then patients are not available for local thrombolysis. And again, the two cohorts are completely homogeneous regarding the site of the distal anastomosis. Another important thing is this. These patients are very, very complex with on average 3 previous surgical revascularization in the same leg. About the treatment, there are 3 significant differences. The length of operation, that is about the half in the MAF group. The blood transfusion are significantly less in the MAF group, and the length of hospitalization about 1/3 in the MAF group. Regarding the follow-up, during follow-up, no differences in reocclusion rate, and the primary hypothesis is in line with the literature data, considering the redo bypass surgery or thrombolysis in patients with previous bypass failure. The only difference is in patency duration. The patency duration is significantly longer in the MAF group. Again, during follow-up, no differences in death rate and limb salvage rate, with a limb salvage rate quite good, about 90% in both groups. The second part of our study is dedicated to the cost evaluation. In this table, we summarize the cost in both groups. But if we consider separately the intraoperative and the post, in this table, that into the intraoperative period, MAF is more expensive than open surgery, probably due to the cost of the Rotarex and the other endovascular devices. But if we consider the post-operative period, MAF is significantly less expensive than open surgery due to the less discharge. Then, considering the total admission cost, we can say that open surgery costs on average 1,500 euros more than MAF for every patient. And of course, applying the cost effectiveness analysis, MAF is a dominant therapy in this case. And then the conclusion, the take-home message of our study is that, of course, MAF is less invasive than open surgery, is less time consuming, but is also less expensive and producing a greater health benefit with a longer reocclusion time. Thank you.
Thank you very much, Dr. Migliara. Very interesting presentation, also not only from the clinical point of view, but also from the cost effectiveness point of view. Really, really nice. Thank you very much. If you agree, we keep the questions that are coming in the question and Q&A tab for the end. We will go through the presentation and then we will keep the question and answer for the end. Okay. So now I pass the power of controlling and presenting to Dr. Isernia. Yes, now we can see the presentation. Thank you very much.
Thank you. First of all, I want to thank Straub for this opportunity to be part of this scientific webinar during a tough world situation. It's a pleasure to be here with a knowledge QL such as Dr. Bruno Migliara and Dr. Freitas. In my center, we have a quite large experience with Rotarex in the different arterial path. And in particular, I want to show you how could be effective this device to manage iliac thrombosis in EVAR patient. Just in order to keep in mind the magnitude of limb occlusion event after EVAR. The ENGAGE study was a multicentric registry designed to report a real-world outcome with up 1,000 patients with 2 years of concrete follow-up. Regarding the data literature, the limb occlusion rate ranged from 0 to 7.2%, and in this specific study, they presented a 3.4% of occlusion in 39 patients. At multivariate analysis, the independent predictor of limb thrombosis of the study were the distal landing zone on external iliac artery, the external iliac artery diameter, and the iliac limb diameter less than 10 millimeters, and the iliac limb kinking. I want also to underline that more than 2/3 of all occlusion had occurred by 6 months after the previous intervention. A second crucial issue is related to the clinical finding after limb thrombosis. As shown in this article published in 2004 by Cleveland Clinic Group, 68% of patients with this condition develop a CLTI with severe rest pain and ischemia. The surgical approach failure was directly attributed to donor limb occlusion in 67% of patients. An endovascular approach did identify an underlying treatable cause in 8 of 12 patients. This consideration for me adds value and is the current base of endovascular approach in iliac occlusion management after EVER. Let's move to practical, proving how effective it is Rotarex device in this condition. This is a clinical case of a 78-year-old male patient affected by arterial hypertension with a previous EVER in May 2019 and with an asymptomatic peripheral artery disease. This is the event timeline. 6 months later, the patient suffered by a right acute limb ischemia, treated with a femoral crossover bypass in another institution. 2 months later, he presented again a rest pain with a CTA finding of bypass occlusion. Due to the symptoms, we can conclude that the bypass occlusion probably occurred within 40 days. This is the preoperative CT angiogram in axial view, in which you can clearly see the right limb occlusion, the previous surgery with the occluded bypass graft. My strategy was to use the 10 French Rotarex device in order to maximize the aspiration and the fragmentation power, removing as much clot as possible. I started as usual with an echo-guided common femoral artery puncture, and in the right you can see also the angiogram that show a correct puncture and also a very tight and a narrow external iliac artery. Considering also the previous femoral bypass, I went for a percutaneous approach with a single reimplantation of a perclose proglide in a standard fashion. I approached the occlusion with an A18 guide wire and a 5 French diagnostic angiographic catheter, a Bernstein 2. You can clearly see that we were facing with different type of clot inside the graft, and it's not really easy to cross the occlusion. In the right side, we see the angiogram with the patency of the main body of the graft and limb. In this situation, it's usually recommended a contralateral occlusion, but considering previous femoral cut down and a diseased thoracic aorta, like you can easily see in the image, I didn't use this precaution indeed. This is the procedural detail in which it's essential to use a full heparinization of the patient with 100 units per kilo, and if it's possible, to check the activated clotting time that must be up to 150 seconds. It's very useful also to use a big introducer sheet like a 12 French in order to maximize the infusion of saline during the procedure. It's mandatory also the adoption of a dedicated guide wire For the 10 French, the guide wire is a 025 guide wire, and for the 6 French and 8 French is a 018 nitinol guide wire. In my opinion, the operative technique is crucial, with a slow push and pull movement, as you can see in the video, and it's very important always to check the blood flow through the reservoir in order to control, to have a blood flow near the rotational head. Also, in this kind of situation, you approach with a retrograde approach. The infusion of saline for the introducer sheet is necessary. It's also important to support the Rotarex with the introducer sheet in order also to reduce an overheating of the rotational head. Finally, you must retrieve the device in aspiration to remove as much clot as possible and to avoid any kind of distal embolization. The endovascular benefit of this procedure is to create a new lumen inside the graft and to remove a large amount of thrombus and chronic clot. But in my opinion, the most important point is to reveal an underlying treatable cause of limb occlusion. In this case, probably the main cause of occlusion was related to this calcified plaque just below the end of the graft, as you can see in the 3D reconstruction and also in the intraoperative angiogram after the passage of Rotarex. So to complete the procedure, it's necessary to put it in a cover stent graft in order to realign all the previous one. It's very important also to mold this new stent graft with a non-compliant balloon. I used, in this case, a 14 by 40 balloon to create a very well a position of the new graft inside the previous one. To complete the procedure, obviously, it's necessary to treat the stenosis at the end of the endograft with an uncovered nitinol stent. This is the final angiogram with a nice patency of the right iliac leg and a pulsatile flow through the femoral axis. Dear colleague, in conclusion, nowadays endovascular management of iliac limb occlusion allow an high technical success and could be considered a first-line strategy. Rotarex device is safe and effective in acute, subacute, and chronic setting, combining a thrombectomy and debulking mechanism. Procedural tips and tricks is necessary to maximize clinical results and to avoid any kind of complication. Thank you for the attention.
Thank you very much, Dr. Nisani. A very nice case, a very nice experience that you're sharing with us. Thank you very much. I think this is a very interesting indication, and as your last point here, tips and tricks are necessary. Questions are coming. We will see again at the end the questions that are coming, and maybe to underline again the most important tips and tricks for a successful case. Thank you again.
Okay, perfect.
Now, Dr. Bruno Freitas, I already see your presentation here, so thank you, and we will enjoy your presentation now.
Oh, my pleasure. I hope you guys can hear me well. If there is any issues, please tell me. I mean, we shall.
Yes, okay.
It's a pleasure to be here. Thank you very much for Straub for the invitation. I hope this can be interactive as we finish this presentation and can discuss also the other topics from my noble colleagues. We'll talk a little bit about in-stent arterial lesions and how we think that also this tool is extremely pragmatic and easy to use, and it's actually our first option in this kind of treatment. Let me see. Can you guys see it now?
Yeah, maybe now we can see. Maybe if you click on the presentation, it will then start moving.
Well, okay. So, in terms of a physiopathological pattern, we know that up to 14 days we had an acute lesion, and after 3 months we have a chronic lesions. And but we know that I would like to highlight a distinguished concept of a fragmentable lesion. Whether a lesion into a vessel, into a bypass, into a stent, into a covered stent, it's chronic or acute, I think that in terms of surgical approach, in terms of endovascular approach, in terms of considering the use of this technology, having an insight, previous insight, whether you have a soft core lesion, and this is made by during the guide wire passage, even if the lesion is long, if the lesion is old, this is probably the most important aspect we take in consideration when we think about using this technology. And by that, I would like to clearly state, if you are in a lesion that you were able to stay interluminal, no matter how long and how old it was, and then come back to the true lumen, and you thought it was a little bit easier than you expected, it's a very interesting tool to use, especially if we consider that, for instance, our great colleague Bruno just showed his huge experience with bypasses. Venous bypasses and prosthetic bypasses specifically, they work pretty much as covered stents. So they tend to have their culprit lesions on the edge, and then you have a positional thrombus, organized or not, in the middle. So what you have in most of those patients is a fragmentable lesion. This is highly, highly effective with this device, with Rotarex. So as you look to the left side of the two pictures here on the left side, you see that they look like acute, even though they were chronic. They were 4-month-old in-stent lesion. If you look to the right, they look pretty much chronic with a lot of collaterals and everything, but this was a 5-day history patient. So sometimes it's difficult to distinguish between those. It's not so easy. But what we know is that occlusions are at high risk of recurrent in-stent restenosis after reintervention. So it's important to treat adequately those patients, and if possible, to leave less metal behind, as we can see here in the subacute 2 months in-stent occlusion, right, SFA occlusion. And normally what we do is we pass with Rotarex extremely calmly. We give time to the device to work properly, just as Bruno mentioned. And then after that, you find the culprit lesion. You complement your treatment with a drug-eluting device in this case, and then you have a very interesting final result, as we can see here. Very decent final result to the foot. Another thing that I find very interesting is that this is a device that can work from the belly to the toe, almost. So from the belly to the early part of the lower limb, you can work with it. Here we have a very old patient, obese, coronary artery diseased. He had also a little bit of renal insufficiency. He had a subacute 2 months stenosis. So here we have an angiogram, a very long lesion. As you can see, we have almost no flow in the knee region. We have a late refilling. And as you can see here, we are puncturing an occluded segment, and we have a stent. We had 2 stents previously implanted in other department. This was not one of our patients. And we faced some difficulties, but the guide wires goes with the support of a normal catheter. And as you can see here, we are planning to have a lot of difficulties, but the guide wire comes back to the lumen. So in about 5 minutes, we were able to cross the whole lesion and be back to the true lumen. This is a patient that it's interesting to use. Can you see that we have a huge difference in diameters in terms of proximal and distal stents? I don't know what happened here, but it was in another department. But I would like to highlight that after passing the Aspirex, we see that there is material here in the middle, in the proximal part, that we need to pass again the device. But we already know where the lesion is, that we have a proximal culprit lesion, as you can see here in the angio, very calcified. And then there is no need to worry about anymore. We'll just pass it a little bit more proximal to clean the proximal part, as you can see here. Then we go for ballooning, as you guys can observe in the proximal part, relining of everything. and we have a very decent result after that. So here we have another case of a very, very long in-stent chronic occlusion. We see nothing in the SFA. We have stents from above to the end. And we have only a fibular artery, as you guys can see here, filling up to the foot. And here we are passing with the guide wire. It's not that easy, but we managed to go all the way up to the tibial trunk, to the P3 segment, and we are in. And then after that, as you can see, we started moving the device. You can see that the stent almost shrinks. And then as we go from above, below, we see that we have culprit lesions. In this scenario here, we see culprit lesions. In the iliac, we also had some lesions in stent, as you can see here. But the device was able to clean a first passage very well until the fibular artery. Then we go for ballooning. We have a preliminary good result in the iliac, and then ballooning with drug-eluting in the whole device and the whole segment, and then the final result, very interesting. So we have some experience with this that was built up initially in Leipzig. We're also building up some experience in here, but in terms of in-stent, we do have a little bit more than 330 patients. I mean, a very usual, ordinary demographic cohort of patients, nothing that calls attention. But something I would like to highlight is that more than 78% of the patients, they had more than 14 days, and almost 45% of the patients were chronic patients. And as you can see, most of them were from Rotarex 3 to 5. Most of the procedures were done by crossover, and this is explained because there were long lesions, most of them in the SFA and POP segment, but we did have iliac and also below the knee lesions. I would say that more than 77% of the patients did have moderate to severe calcifications, with half of them being long occlusions. We had a very good success procedural rate of more than 96%. And this I would like to highlight. This is not a solely event. We only treated with Rotarex 21% of the patients. Most of the patients were treated with Rotarex plus PTA, and we did stent patients in almost 12 to 13% of the patients, but those patients were treated with spot stenting, not with long stenting. And we did have 1/4 of the patients to 1/5 that were treated with below the knee treatment, balloon angioplasty mainly. And this is because this is, in many patients, this is a progression of the disease. As we can see, perforation was made, none by the device, mainly by the guide wire. Bleeding was found in also 4.4% of the patients, but the vast majority of them required no surgery at all. We did have a 2.9 dissection and 6.5 emboli. 8 patients had infections. We had 4 patients who died through the early postoperative period. Nothing related to the device itself. We had 6 myocardial infarctions, and we had a major adverse event rate of 6.7%. After 12 months, we had 9.2 mortality, none related to the device again, and a very interesting TLR of 12.7% after 12 months, with a major interpretation rate close to 4%. If we go for Rotarex class evolution and also sustainable evolution after 1 year, we will see that almost 70% of the patients, and those are very chronic, very severe ill patients, they sustain a very good improvement in their Rotarex class. So here's a very complex case of a patient which showed up for us with 2 previous angioplasties for acute occlusions in the POP segment. In the first occlusion, it was implanted a protégé stent in one department. In the second procedure, 1 year before this intervention, it was implanted a Supera. And the patient showed up with a very acute, severe occlusion. We can see the below the knee vessels, but we have occlusion in the same place. As we looked up to the 2 stents, we could see we had a fracture not only in the external stent, which probably motivated the implantation of the superior stent, but also that the superior stent is fractured. And this is highly complex because you have struts of the two stents everywhere. But as you can see, we managed to pass the lesion with a catheter and a guide wire, come back to the through lumen, and then we prepare to pass the Rotarex. I'm just showing this to explain how safe the device is. As we can see here, also after the passage of the Rotarex, you can see now a clear passage to the below the knee vessels. We know where the culprit lesion is, and we treated that with a covered stent. Obviously, I was impressed how a patient could, in 2 years, occlude 2 stents and fracture a supera. So after that, we did an MRI, and we found out that the patient had an entrapment, complete entrapment syndrome. He shouldn't have been treated endovascularly since the first treatment. We treated him adequately. He keeps now almost 4 year patency. He's okay. So what I would like to end up, I'm sorry, this was probably a long presentation, is that we found a very good success rate, very effective, easy to use, friendly, fast procedure with a very low rate of complications, and also a very good clinical result in this sample. It's obviously a single center, retrospectively made a lot of limitations, but this has helped us a lot to build up our confidence in this device. So thank you very much for your kind attention.
Thank you very much, Dr. Freitas. Again, every time I see these numbers, they're really, really interesting, really amazing numbers, a lot of data collected in your Leipzig experience. Thank you very much. I would like to thank you again, the 3 speakers from today. I would start with a Q&A session, if you agree. So first of all, I also would like to launch a survey to our audience in order to see if they usually place a distal filter during this kind of procedures. What is their, their normal procedure strategy? But meanwhile, I would like to hear from you what is your experience. So maybe we can follow the same order as before. So Dr. Migliara, then Dr. Isernia, and then Dr. Freitas about this this subject.
Okay, I can speak. Yeah.
Yeah, we can hear you.
Okay. I never use the filter, the distal filter in this type of patient, because if you use Rotarex in a right way, then if you go very slowly at the end of the occlusion, and also if you check, if you perform the first passage and to stop 1 centimeter, half of centimeter above the distal occlusion, you check with contrast medium injection to see if you have removed all thrombotic material, the risk of distal embolization is very, very low in this case. And then it's not necessary, in my opinion, to use filter in this type of patient, in acute, subacute, in case of 1, 2, or 3 runoff vessel. One thing about the presentation of Giacomo, I have some experience about the treatment of limb occlusion in HIVAR, but in some cases the thrombus extends also at the level of the body of the endoprosthesis, and this is a tricky situation because in this case with Rotarex it's difficult to remove this thrombus. Usually it's a chronic thrombotic material, and then it's very difficult to remove. The body is big. In this case, in some cases, in my opinion, can be helpful to use or a curved sheet, a flexor sheet, or also the Oscar sheet to direct close to the wall of the body of the endoprosthesis to try to remove everything. This is only a little trick that is possible to improve the result. The Bruno from Brazil, my friend. in some cases, in case of a complete occlusion of the stent, it's difficult to go into the stent in integrated way, because the stent usually is placed in a subintimal space. Then in some cases, in my experience, it's difficult to cross in antegrade, and I started to puncture in retrograde the distal tibial, but now I prefer to puncture directly in retrograde way the stent, to be sure that the guide wire is into the stent. This is another small trick to improve the possibility to recanalize the stent. Thank you.
Thank you, Dr. Migliara. I don't know if Dr. Riseni and Dr. Freitas want to add something about the use of filter. I can show you also the results. As you can see here, 92% of our audience does not use normally a filter in accordance.
I totally agree with Dr. Bruno Migliara. I never use distal filter, and it's very, very important to leave a distal cap in a bypass or inside the stent, in order to cross the distal cap at the end of the procedure, and to use the aspiration power of the device to remove all the clot inside the graft or what else. And regarding the suggest of Bruno, yes, of course, the patient with limb occlusion with a stratified thrombus in the main body of the endograft is a very tough condition, and probably in that case it's very useful to put it in a contralateral balloon in order to prevent a contralateral embolism. In that case I use a contralateral balloon, and sometimes also after the passage of Rotarex with a steerable sheet or what else, you have to realign both the legs in a chimney fashion, with two legs or with a main body in the proximal part, of course. And this appears also with the old device, old endograft device. With the new device, aortic device, in my experience, I never see a big amount of thrombus in the proximal part of the endograft.
Okay. Thank you very much. Dr. Freitas, if you want to add some comment also to the crossing of the guide wire suggestion from Dr. Migliara.
Well, first, I agree with the two guys. I mean, two wonderful tips. Regarding filter, the only situation where I use filter for legal issues here in Brazil is when I have a single vessel runoff, and I'm able to deploy a filter. I do deploy the filter because of legal issues, but it's not generally not necessary to use. It's generally not necessary to use so. I mean, if you do just like Bruno just mentioned. Regarding aorta, if you do not have eventually the kinked sheath from Cook or whatever, you can contralateral iliac balloon in order to subocclude a little bit your iliac, because the Rotarex will go to your side, and then you take it out. You have cleaned this side, then you go with the balloon, enter with the Rotarex with the other side. It'll hit the balloon and go and enhance also the capabilities. But these are extreme cases. I agree with Bruno that if possible, another strategy should be thought if you have severe material into a big aortic body. I mean, the effectiveness is not that good. But if you need to do it, and we have done it in very severe ill patients, cardiac arrested, so very bad ventricular ejection rates, so you need to try to do something. And this is why we invent, just like my two colleagues, Giacomo and Bruno just mentioned, we need to reinvent options to make it work. And in terms of the stent, apparently my angioguard was awakened in that case, and I was able to make a loop and pass through the hole. But this happens sometimes, I agree with Bruno, in the fantastic world of Bob, especially if you have an uncoupling or if you have two stents, you normally get into the lumen to the first one and then into the second, you can't. So in this kind of scenario, I really puncture the stent. It's an occluded segment. It's an occluded stent. It's very safe. And you're sure that you are into the lumen you capture. So I agree with Bruno completely.
Okay.
Very good. Thank you very much. Again, maybe we can, questions are coming from our audience, and maybe we can discuss a little bit also. Okay, today we discussed about stent indication, bypass occlusions, EVARS occlusion. We don't forget that we also have the novel lesion treatment that we can do with Rotarex. Do you have a different approach when you are in an antegrade way, the guide wire, you're not sure that is endoluminal, and we remember that subintimal passage for a guide wire is a limitation for Rotarex. So do you have a different approach between a stent or a de novo lesion, or you go trying recrossing, you can puncture in a retrograde way? What is your strategy when you are not sure to be endoluminal in this situation?
Well, usually, okay, in acute occlusion, usually there are a problem. You are sure that the guide wire go well through the occlusion, then you are sure the guide wire is into the true lumen. The problem is in subacute and above all, of course, in chronic occlusion. In case of chronic occlusion, in some cases it's very difficult. I try to use a specific guide wire to be sure the guide wire to improve to stay into the lumen, then with the SI guide wire to try to drill the guide wire to cross intraluminal the occlusion. In some cases, if in a little part there is the duct to be subintimal, I think no problem. I go with Rotarex. In other cases, when the guide wire had a loop, and then I sure the guide wire in antegrade way is subintimal, of course I can try from in retrograde way, or I stop and I change my strategy. I perform PTA, eventually I put a stent. This is my opinion. In chronic lesion is more difficult to understand where is the guide wire. Then in some cases I stop with my idea to use Rotarex and change completely my strategy. I perform PTA and eventually the stent.
Okay, thank you. Dr. Isena, Dr. Freitas, I don't know if you want to add something, otherwise I have other questions coming, so just let me know if you want. Okay, so question for Dr. Isena is regarding the 10 French Rotarex. You know that the question is, are you concerned when you're using a 10 French Rotarex about the aspiration of blood in the patient, as the 10 French is bigger than the 6 and the 8?
Okay, no, really not, because in particular when you manage iliac thrombosis, you perform a retrograde access, so you do not have a direct flow. And I'm not concerned about the aspiration of the French. In the other side, it's important to have a big aspiration and a big power of fragmentation, because the material inside the legs is tough. So it's important to have a big device, and it's also very, very important. I remember to use a big introducer sheet in order to have a correct infusion of saline to reduce the heat of the Rotarex, and also to improve the removement and the aspiration of the device.
Thank you, very clear. Thank you very much. Dr. Freitas, a couple of questions about stent treatment. First of all, we had a question regarding what to do when you have a fracture stent. I mean, some advices in order not to worsen the situation there. And then another question regarding the filter. So then maybe you can give us an idea in general. What do you do when you place a filter? So you use the 19 guide wire for the Rotarex, and then you place a body guide wire for the filter. I mean, a little bit of the technique of how you place the filter and the use of the filter together with Rotarex.
Thank you. So the first question was about stent fracture.
Yeah.
So we need just to remember that we have theoretically 3 stages of fracture. You have fracture grade 1, 2, and 3, up to 30% of the whole circumference with no de-alignment, so the stent stays aligned. So from 30 to 50, and the stent may be aligned or de-aligned, and then you have above 50 an uncoupling, or you have a severe de-alignment of the stent. So the strategies are not the same, but the main point is whether you can stay the whole time into the lumen of the stent. If you're into the lumen of the stent, and if there is no severe intrusion of the struts of the stent into the lumen, you can pass Rotarex without no difficulty. So, and no danger, I would say, or very low danger. This is not true if we're thinking about other atherectomy devices, and by that namely, I would say Hawk 1. We had some severe complications with the strut can be sticking into the device, and then it's quite difficult to take it out. As Rotarex has an undo button, so if eventually you get in a difficult situation, you can undo. Another thing is that you should not turn on the device and keep it working the whole way. As you can see, there is a high aspirational capacity. It can suck the stent. It can shrink the stent. So you should keep watching it very properly. And as you see this is sinking, smashing, that you're sucking the stent, you should stop a little bit, allow the stent to come back. Flow will come into the device, and then you move on safely. In terms of filter, we prefer to deploy, if necessary, an 014 stainless steel core guide wire, for instance, V14 from Boston. And then we deploy the filter and we run the device over this system. But as I told you, this is very, very exceptional. And honestly, because of where I lived in Germany, we had very frequent some legal issues. If we have one vessel run off, even though the embolization rate is very low, I have to say that in my practice, I do deploy a filter.
Okay. Then, Dr. Migliara, if you can give us an idea about venous bypass treatment with Rotarex. We've seen graft bypass treatment with Rotarex. What about venous? What we can do about it?
Venous bypass, of course, is the most difficult to treat, also in open surgery with other devices. And in case of an occlusion of a patient, there aren't other vein to perform a new bypass, and then this is a big problem. In case of acute occlusion, it's possible to treat. In this case, and also in our study, we perform in 2 cases. We used in 2 cases Aspirex, because if it's an acute occlusion, it's possible to aspirate the thrombus with Aspirex, and this reduces the risk of interaction and wall damage of the bypass, because in one case I had a perforation of the bypass, probably due to a residual portion of a valve in a previous devalvulation, because it was in situ vein bypass. And then now, in case of acute occlusion, I prefer to use Aspirex. In case of chronic occlusion, is the only situation in where it's impossible to reopen, because the vein bypass in case of chronic occlusion is completely collapsed, and then it's impossible to recanalize, in my experience.
Okay. Thank you very much. Dr. Rizeni, a question for you is regarding the strategy or the reason why you decide to realign a prosthesis with a stent, and which kind of stent, if you have some stent, you recommend, or in your experience.
Okay, this is a critical issue because it's very important to consider that the iliac endograft has leg up to 10 millimeters, so it's impossible to remove all the clot inside the graft. There is also, as said before by Dr. Freitas, different type of clot inside the graft, probably a fresh one, probably a chronic one. So the gain is to obtain a new huge lumen with, in this case, a 10 French device. But in my opinion, you always must realign the previous stent graft in this case. The stent graft you must use depends in particular in the diameter of the docking zone of the previous endograft, and obviously about the diameter of the distal part of the iliac leg. Sometimes you could have 20 millimeter in distal diameter, so you must use the same leg you used before. And it's very important also to mold this new stent, and I suggest clearly a PTA balloon and not a compliant balloon for doing this work.
Thank you very much. I have a question about another important topic, interesting. Also, it was debated a little bit in the last few years about DCB. Dr. Freitas, what do you think about the use of DCB after Rotarex in treating of a stent? Is it something that you normally do, you usually do in your daily practice?
Well, thanks for the question. We have a lot of debate when we talk about in-stent, in-bypass approach with drug-eluting device, especially because what type of lesion are we treating? So what is the histological aspect of the lesion? And we are probably not talking about the same lesion, whether you are treating an occluded bypass, a biological bypass. There are some slight differences if you're treating an occluded prosthetic bypass. And also, we have some differences that we know that appear in terms of histological aspect as we treat in-stent occlusions. But in general terms, all of those are distinct from pure atherosclerotic lesions. So, but anyway, despite of these lesions, for the use of drug-eluting device in this territory. We do have a paper that we are now finalizing, and we are comparing the treatment of Rotarex with plain, with POBA, and Rotarex with drug-eluting balloon, and we did have a statistical difference. Also, when we compare with well-known papers with solely drug-eluting balloons in this device. So there, we need to remember that this device not only clean, but also debulks. So we have some kind of debulking, especially, and this also may help to enhance the response in native vessel occlusion. But this has obviously to be proven by adequate prospective randomized trial. But yes, regarding stents, we do have some very interesting data published, and also personal that we are working to publish very, very soon. And that points out to a very significant benefit of joining a Rotarex plus drug-eluting balloon. And this is our first strategy when possible. As you can see, we have almost 60% of patients that were treated with a Rotarex and drug-eluting balloon.
Perfect. Thank you very much. I don't know if Dr. Migliara, you want to add something. Otherwise, we have a last final question. We are perfectly in line with the timing. So a general question regarding the distal runoff, the importance of having a distal runoff when treating this kind of patients. So Dr. Migliara, maybe we can start from you, and then we do a final round also with Dr. Risani and Dr. Freitas before closing this session.
Of course, so when we treat above all patient with CLTI, then a patient with a very tricky situation, also in BTK vessels, probably in some of these patients, the occlusion of the bypass and also the stent occlusion is due to the problem in the runoff. And then usually when we treat this type of patient, we perform also a PTA and BTK vessel in order to try to obtain two vessels to improve the runoff and to improve the flow to the stent or the bypass. This is usually our choice.
From my side, it's well known that a good runoff vessel up to or 3 vessels is necessary, in particular in the endovascular approach of superficial femoral artery. But also as a surgeon, in surgery we know that the patency of the graft, venous graft or bypass graft, is related absolutely also with the runoff. So if it's possible, I try to increase my runoff, gain the second vessel in below the knee arteries. Yes, I have also another comment for my colleague regarding the medical strategy after Rotarex for this patient. What is your advice?
When I use Rotarex, usually after the treatment, in case of in-stent restenosis or occlusion, I use in every patient a drug-eluting balloon, and after about the medical treatment, I use the double antiplatelet therapy, usually for 3 or 6 months. In case of bypass, it's a little bit different because in case of venous bypass or composite bypass, usually we prefer to combine anticoagulation, low dose of anticoagulation with 1 antiplatelet therapy. In case of prosthetic bypass, is a little bit more complex. Usually we perform a double antiplatelet therapy, but usually we try to, also in case of a prosthetic bypass, in every patient we place a distal vein cuff, and then we treat this bypass like a composite bypass. In case of below the knee, in case of above the knee, of course, in case of prosthetic bypass, I prefer the double antiplatelet therapy.
Lorenzo, just one thing. I know that this stuff is being recorded, you know? So we need to say that, I mean, what you did with Bruno just now was pretty mean, you know? I mean,
it wasn't meant to be.
I probably do the same thing, but the level of evidence that I do the same thing, but the level of evidence that we have will probably change in about 1 or 2 years. So this is something that it's very important for us to discuss here, because Bruno and Giacomo have great experience with what they do. But our opinion can change in about 1 year or 2, as we know that many studies in this issue specifically are coming up. But yes.
Thank you. You know, in 1 year we'll be here discussing about cases again, and we will see which new strategies we have. So don't worry, we will record also the future ones, so we can store it, and then we can show what you prefer. Of course, I'm joking. From the bottom of my heart, I would like to thank you very much for your time for today. I would like to thank Sergio, which was behind the scene, taking care of the questions, passing me the question to ask you. Thank you very much, Sergio.
Thank you.
Thank you very much, Dr. Freitas. Thank you very much, Dr. Migliara. Thank you very much, Dr. Isernia. It was a real pleasure. I think it was really interesting. And so also, I would like to thank our audience who stayed connected for more than 1 hour with us today. And I hope to see all of you again in the next future. Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Bye. Bye.